So this is the challenge, and these aren't new to any of us, right? We have fragmented care coordination, access to care, things that Julie mentioned, and something, I don't know where you all are from, but here in the South, there's a lot of rural population, and it's underserved, and rural hospitals are closing. I think I read somewhere where something like 400 and something rural hospitals are in danger of closing within the next 3 years, and that's already on top of the 100 and something that have already closed. Overutilization, overtreatment, overuse, poor medication management, we see this a lot, and adherence, obviously that's the biggest thing, is okay, you got the meds, but are you taking them, and are you taking them appropriately? And non-consumer centered. So, you know, we're not thinking of the patient in terms of a consumer, and they have all the power. These are some pretty interesting statistics. 10,000 people every day are turning 65, and the 80-plus segment is growing the fastest. And this is frightening. 85% of older adults have at least one chronic disease, and 60% have two, according to the CDC. And this population here, the Medicare patients over 65, 2 million of them are homebound, and an additional 1 million are home limited. And when you add declines in marriage, increases in divorce, and lower fertility, that means that more baby boomers will reach 65 without a spouse or adult to rely on care. So these are our clinical pillars. So we have the care process, where we're team-based. We work in a team-based model with interdisciplinary clinicians. Our care programs are care complex, so it's chronic patients, ongoing. We act as a PCP or an adjunct to the PCP in the home. We have Care Now. As part of that care complex, we have a transition of care program as well. And Care Assess is where we do in-home assessments, annual wellness, close HEDIS gaps, things of that nature. We have a behavioral health focus, a palliative care focus, and the clinical PCP model that I mentioned, where we have a predictive index, where we analyze data, patient data, and risk stratify patients, and manage those patients as a primary care physician in the home. So this here shows, I'm sorry, I think I skipped a slide. Oh, it is, yeah. So this shows our care programs in a little bit more detail. As I mentioned, our care complex, that's the one where we manage chronic care patient management in the home. We have proprietary RPM, so remote patient monitoring for preventive care to reverse potentially preventable events. We're a PCP at home, including ongoing management, caregiver engagement, and palliative care and hospice transfer. In our transition of care, we work in 30, 60, and 90-day programs, post-ED and/or hospitalization. Our Care Now is, we have a telemed platform, and so it's obviously we're available 24/7, 365 days, both via telemed and through our in-home primary care. So as I mentioned, here's our team-based care management. So we have interdisciplinary clinicians, from physicians to ARNPs, mid-levels, PAs, RN case management, and pharmacists, social workers, psychiatrists, and palliative care experts. We provide personalized consumer-centered care at home and via telemed. So here are some of the tools and analytics we use. As I mentioned, we have our proprietary remote patient monitoring for high-risk members. I'm sure you all are familiar with the LACE predictive tool for risk assessment for hospital readmission. And we use Johns Hopkins ACG to risk stratify our patients. And so some of the things that we do through the clinical care coordination through care management teams are targeted disease management programs, targeted member and caregiver education and outreach. And this is sort of our lay system that we use where we assign the score. And so these are some of the measures that we incorporate into our risk stratification and our Johns Hopkins ACG predictive index tool. And so what that does is we gather data from the plan, and the plan provides us with claims data, pharmacy data, and patient data. And these analytics allow the health plans, the PCPs, and the MSOs and health systems identify high utilizing members driving MLR and medical costs. So to talk about some of the, when we talk about transition of care, we want to reduce potentially preventable readmissions. And so some of the things that we use to do that is we obviously are coordinating services post-discharge with hospital case management. We're educating the enrollees and their family members on discharge instructions and medication adherence. And then 24 hours after, we follow up with a home visit. And if need be, we coordinate any community resources with the patient. The risk stratification tool that we showed is used to identify members with the highest risk of the 30-day readmission, and we use targeted intensive care RN case management. So we increase case management and care coordination, telemonitoring care programs. Behavioral health is obviously a big focus. We talk about, the non-medical and how important that is. And we have the telemed behavioral health psychiatrists that are managing that in coordination with the rest of the team. So here's a particular case study that we did for a transition of care for a health plan in South Florida, a Medicare Advantage plan, Care Plus, and it shows the discharges that we refer to us, the average discharge to a readmission day, and then it shows readmissions, number of members seen. Obviously, we don't always see 100% of the members that we get, and it shows sort of the impact that we had on readmission rates. And the referrals that we had received from this plan had a readmission rate of 35% plus before being placed in our care program. So we had significant impact on that health plan. And here shows some data from some health plans showing on the left side, you see that's on the chronic care program where we impacted hospitalizations 58% fewer, emergency room visits 71%, and the right side graph is our transition of care where we had impact there as well, significant impact. So part of what, one of the slides, the earlier slides that we showed was sort of the kind of demographics and a population that's in need of home-based primary care and the elderly population, so forth, access to care, underserved rural populations. But what it does is, these access to care means missed appointments, fragmented care, poor control of chronic conditions, and the staggering statistics of the patients or a number of Americans actually that are 65 and older are projected to nearly double from 52 million in 2018 to 95 million by 2060. And the 65 and older age group's share of the total population will rise from 16% to 23% And, you know, the chronic conditions, 85% of the older adults have at least one, 60% have at least two. 4 chronic diseases, heart disease, cancer, stroke, and diabetes cause almost 2/3 of all the deaths each year. More than half of all people aged 80 and older have a severe disability, and at least 30% require assistance with activities of daily living. Over 1/4 of women aged 65 to 74 live alone in 2018. This share jumped to 39% among women ages 75 to 84, and 55% among women older than 85. So our average patient that we see in the home is 73 to 78 years old, has at least 3 chronic conditions, and takes more than 12 medications. More than 50% struggle with social and behavioral comorbidities that are frequently untreated. And the following is a case study of an actual patient. Let me see if I can get here. Here's case number 1. A fully ambulatory 65-year-old male diabetic with concomitant mental illness and alcoholism. He was poorly adherent to his diabetic regime, and over a 21-month period, he had 44 ED visits and 27 hospitalizations, over half in the intensive care unit for diabetic ketoacidosis. Frequent home visits were made to engage the patient in his care, and behavioral health clinicians were consulted. New glasses were purchased, which enabled the patient to read his insulin syringes. Really easy, right? After home visits were initiated, the patient's adherence and quality of life dramatically improved, and he required only 1 hospitalization over the next 2 years. I mean, that is huge. And those are things that you can only see by going into the patient's home and managing the patient preventively, longitudinally. Here's another case. 82-year-old woman, previously hospitalized 13 times for conditions such as heart failure and pneumonia, with multiple rehabilitation stays following these hospitalizations. She was reliant on her 86-year-old husband as a primary caregiver and wanted to avoid being hospitalized again. With home-based primary care in place, she only required 1 more hospitalization over the course of 8 months, and in the end, was able to pass away peacefully at home, something she also wanted after transitioning to hospice care. Her quality of life during the last 8 months was dramatically improved, and her husband voiced immense appreciation for the help he received. As I mentioned, one of the, our clinical pillars that we are experts, starting in South Florida, with a huge Medicare population. We are, a big focus of ours is palliative care and end-of-life dialogue, and we talk about here, we show some data that pre-My Home Doctor and post-My Home Doctor, where it's 125 days versus 32 days transferring to hospice. Those are difficult conversations, but our team is experts on that, and as you saw from the previous case, that made a huge difference in that woman's life and her husband's. And so this is what we do. We try and disrupt the healthcare delivery experience by providing primary care when and where members need it most, at home. So thank you. I apologize for the hiccups with the videos. You should probably YouTube that Comedy Central video because it's really funny, and it would have been better if we would have been able to see it. I didn't do it justice. So thank you for your time. If you guys have any questions, I'm open to any questions.
Thank you, Omar. And we all feel your pain in that.
Yes.
Thank you for rolling with the.
Any questions?
Yes.
On an average, how many patients are you able to see a day with this program?
On average, so we have about 350 clinicians, and we see on average about 7,000 patients a month. So it really depends on the type of program what we're seeing, but in a chronic management program where we're seeing the patients in the home, it really depends geographically where we are, but we can see we have a team-based approach, so we can see up to 120 patients a day. And so we are, as I mentioned, we were formed and started in South Florida. That's where our headquarters are. I live here in Marietta, Georgia. We are in Florida, Georgia, Alabama, South Carolina, Tennessee, Illinois, New York, New Jersey, and I think that's it for now. But I mean, we're a national company.
I actually have two questions.
Yes.
Do you guys ever consider transferring from the geriatric population to the pediatric medically complex? I know that in New York specifically, there's a desperate need for that. I know it's throughout, and there's very few programs that deal with the pediatric population.
So we started really managing most of the pediatric population in the beginning as sort of an urgent care response, an acute response. We have had discussions with a specific payer about that, and so we typically will work with health plans. So we work directly with health plans in value-based contracting, and most of what we've done is, because Medicare Advantage provides a lot of money, let's not kid ourselves, to health plans. They have the ability to manage this patient population, or the financial resources to manage this patient population. The commercial payers, which would probably be in this case pediatric, for the pediatric patients is a little bit more of a challenge. But that's not saying that we have the expertise to do it, and we see pediatric patients. So the long answer to your question is yes. The short answer is we're still kind of figuring that part out.
Okay, because I don't mean regular pediatrics, I mean medically complex.
Yes, I understand that, yes.
Okay, and do you deal with invasive respiratory as well? Like, will you be the primary for a patient who's on a ventilator at home? Do you bring in respiratory therapists? How do you handle that?
So we do have respiratory therapists. Obviously, COPD is a big driver of complex chronic patients. So part of our RPM is we have some ability to do that. Now, there are certain restrictions. I think home health, depending on what their involvement is, but we work in conjunction with home health. So yes, we do.
So I have thank you for a very nice presentation in spite of your
Yes,
troubles.
thank you.
I have a couple of questions. One is, what's the continuity of care like for these people in terms of the physician that goes and makes the home visits? Is it, the same physician every time?
Yes.
So they have a panel?
Yeah, so so typically the physician sits at the top, and so the physician will do the initial visit and subsequent visits as necessary, but it's part of a team, so we have nurse practitioners, PAs, and we have a whole team based on the patient's particular condition, but it's the same team.
It's the same team?
It's the same team, yes.
Throughout?
Yes,
Okay.
so, yes.
And then
now, it's not unlikely that the patient could potentially see a different physician.
Yes.
But more often than not, it is the same team that manages that patient.
So the physician may go out once in a while, but the
Yes.
team is,
Yes. I would say that more often than not, the physician will do the first initial visit, and then thereafter, it's mostly a nurse practitioner or PA. But the physician is still involved in the care. So while he may physically not be in front of the patient every single time, they are involved in the total care of the patient.
and is this team, or primarily the physician, on staff at the hospital that these patients would be admitted or readmitted to? Or is it completely?
No.
How do you interface with the healthcare system that's in the catchment area for this patient?
Yeah,
I guess?
and so the case management.
Okay,
So yeah, so they would contact us through case management, and then that's when the care coordination would start. If the
Okay.
patient is inpatient, if the patient was in the ER and going to be hospitalized, then they would notify us. Typically, if we're lucky, if the patient is, we already have contract with that particular health plan. But yeah, we don't necessarily interface directly with hospitalists, I guess.
okay, right, okay, thank you. Thanks again.
You're welcome.
So you mentioned that you use remote patient monitoring, so I've got a couple of questions around that. Do you monitor all of your patients, or is that based on the risk stratification?
It's based on the risk stratification.
Okay,
yes.
and then is that built into your cost, or are you billing for the RPM to insurance companies or Medicare Advantage plans?
So yes, it is built into our cost, yes.
Okay.
So what we would bill the health plan.
So you're
And then
not,
we have standalone just doing that, remote patient monitoring. But as part of our chronic, where we're the primary care physician in the home, it's built into our cost.
so you're not using any of the RPM codes to bill that at all? Okay.
When it's part of our plan, it's not.
Okay.
But when it's by itself, yes.
Yes, okay, gotcha. All right, thank you.
You're welcome. Thank you very much.